From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Andre Kumar, who is an Associate Professor in the Division of Hospital Medicine at Stanford University in Stanford, California. Today we will be discussing a JAMA article that he co-authored with Dr. Lee titled Point-of-Care Ultrasound for the Diagnosis of Pneumonia. This article was published online in JAMA on June 3rd. There's a link to the article and an associated video in the episode description. Dr. Kumar, thank you so much for joining us on this podcast.
Thank you. I'm very excited to be here.
Your article mentions that community-acquired pneumonia accounts for 1.4 million emergency department visits and 740,000 hospitalizations annually in the U.S., and the most common diagnostic imaging modality is chest radiography. Compared with chest X-ray, CT, or computed tomography has superior diagnostic utility but is more expensive, causes more exposure to radiation, and may be less readily available, especially in lower and middle-income countries. With that background, can you discuss the imaging modality of point-of-care ultrasound, also known as POCUS, and which clinicians are typically performing POCUS?
POCUS refers to the use of portable ultrasound devices used at the bedside to provide real-time diagnostic information. And it differs from traditional ultrasound in the sense that the clinician at the bedside is obtaining and interpreting these images in real time. In clinical practice, POCUS is typically performed by emergency medicine physicians, hospitalists, and primary care clinicians who have the goal of providing immediate diagnostic information regarding a patient.
And what are some advantages, other than being able to interpret them at the bedside, of using POCUS versus the other imaging modalities?
There are, I think, three key benefits of using point-of-care ultrasound over traditional imaging modalities, particularly for pneumonia. The first of which relates to the availability of these devices, particularly in settings where there's not a lot of availability of CT or X-ray for the diagnosis of pneumonia, in particular low income or limited resource settings. In those instances, you can use these tools that can connect to a smartphone or tablet to provide real-time diagnostic information, and that can be very powerful to improving the accuracy of diagnosis in patients who otherwise would not have that option. A second benefit, as you were mentioning earlier, is there's no ionizing radiation emitted from ultrasound. And for patients who are at risk for radiation toxicities or secondary malignancies, it is a wonderful modality to be able to reduce that risk for them. And then I think the third and important aspect of point-of-care ultrasound relates to the expediency. Traditionally, if you are obtaining a CT or an X-ray, it may take a substantial amount of time from placing the order, having it be processed, actually obtaining the examination, and then having a radiologist interpret the examination and the clinician being available to read that interpretation. POCUS is a modality that can speed up that process to provide that information that patients and providers may need to arrive at the next steps of management.
And what are some limitations of POCUS?
There are several limitations of POCUS. Although it has been demonstrated to have a clinical benefit, one of the biggest limitations right now with POCUS is the lack of standardization across societies or by training. I should say that the American Medical Association recognizes the use of POCUS by appropriately trained physicians. However, training in what is appropriately trained differs by specialty. If you look, for instance, at several major societies, such as the Society of Critical Care Medicine, American College of Physicians, American College of Emergency Physicians, to name a few, they all have their own credentialing pathway or course or certificate program in point-of-care ultrasound, but they differ in their scope. And for that reason, there's no set national accreditation in POCUS. Another secondary limitation is POCUS is very much user dependent, and this gets also at the training aspect of it. Users may vary in their technique. There's no set standard technique for acquiring some of these images. And as a result, you may have differences in interpretation. Another aspect of it relates to the patient and the habitus of the patient. Some patients just do not have really great sonographic windows. And for that reason, the diagnostic utility of using POCUS is limited, and you may have differences in interpretation depending on the image being displayed.
And getting into that, what would be some reasons that people would have poor sonographic imaging?
Can be a variety of reasons. It can relate to the amount of adipose tissue on a patient, which can affect how much the ultrasound waves are able to penetrate through deeper tissue. It can relate to particularly when we're thinking of pneumonia in the chest, looking at the space between ribs, and some patients have slightly wider variation in the amount of rib space that they have accessible and that doctors or clinicians are able to visualize. It also relates to the patient's positioning. Point of care ultrasound may require the patient to change positions, very similar to traditional sonography. And patients may not have the mobility, or they may have extreme discomfort or pain when they are in these other positions, and that may limit the exam even further.
So your Inside article focuses on pneumonia, but it is important, and you mentioned this, that lung POCUS can also diagnose other pulmonary conditions such as pneumothorax and pulmonary edema. Let's just start with talking about how the normal lung appears on POCUS.
This is one of my favorite things to talk about when I'm working with learners of POCUS, because when we're initially scanning, they expect to see some organ when we're doing it, particularly for lung ultrasound. And lung on ultrasound looks essentially gray. There's not much of the actual parenchyma that you're able to visualize, and that's because the ultrasound waves are diffracted when they hit air. Ultrasound does not penetrate readily through air, and that's why you're not able to really visualize the lung that well. What we use, though, we use that to our advantage by looking specifically at reverberation artifacts or these patterns on the ultrasound waves that can indicate either a normal lung or an abnormal lung. An example of a normal lung is when the ultrasound wave hits the pleura, it will create this reverberation artifact where you're able to see the pleura and you're able to see repeating ultrasound waves below it, and these are called A lines. If you are able to visualize a pleura with A lines and you see the lung moving back and forth with each breath, that is indicative of a normal lung that you're visualizing. There are many different pathologies that we can go into that can also be indicative of pathology as part of that.
Yeah, so moving on to pneumonia, can you describe POCUS findings that are characteristic of this condition?
There are a couple of characteristic findings. When we think of pneumonia, we often associate that with consolidation. And you can visualize consolidation because the lung has begun to shrink down. It is more dense. There is less air inside of it. And you are able to visualize the parenchyma in that instance. So you can visualize a true consolidation with pneumonia. But that is not as common. The more common finding that you'll see is a artifact that's called a B-line. Now, no one is exactly sure what is the underlying physical mechanism of creating a B-line, but essentially, if I were to describe it, it's a vertical artifact that comes from the pleura that moves all the way down to the bottom of the screen, and it moves with lung sliding. And it is thought to be potentially related to a thickened interlobular septum or alveolar filling process. And these B lines look like a spotlight almost. As you are visualizing the lung, you'll see the spotlight that moves back and forth. And if you are able to visualize B lines in a particular portion of the chest that's more localized, that can be suggestive of pneumonia. And in our particular review, we found that focal B lines, meaning B lines confined to one part of the chest, had the highest specificity, about 0.96. There are also other findings that you can see. Inside the consolidated lung, you can see what is called a air bronchogram or a dynamic air bronchogram. This is essentially when you're looking inside this consolidated lung, you can see air and mucus moving back and forth inside of the lung. And that is also a finding that we found had a very high specificity, approaching 0.96 as well. And then finally, for patients who have more complex pneumonias, such as a peripneumonic effusion or pleural effusion, you can visualize the pleural effusion. It appears as this very large black pool, or this black pool that is essentially the ultrasound waves passing through deeper tissues, and that can also be visualized next to consolidations.
And among those criteria for diagnosing pneumonia, which finding has the highest sensitivity?
There are several studies that have looked at this. The one that we found, one of the largest, was a 2025 meta-analysis that included 26 studies with over 3,400 adults. And that looked at specific criteria, including the ones I just mentioned. And of those, lobar consolidations had the highest sensitivity at about 0.78.
Great. And your article also mentions a meta-analysis I was hoping you could discuss about the diagnostic performance of POCUS for pneumonia compared with the reference standard of chest CT.
Yes, this is of really important interest because we've talked about the potential benefits of POCUS relative to traditional radiography and traditional studies, and that includes both X-ray and CT. And one of the studies, a meta-analysis we looked at from 2025 that included over 1,000 adults with suspected pneumonia, found that POCUS compared to a reference standard of CT had a sensitivity of about 0.9 and a specificity of 0.91 for the diagnosis of pneumonia. And interestingly enough, when you look at different meta-analyses, different studies, including this one, the diagnostic comparison between POCUS and X-ray, you find that point-of-care ultrasound, when in the hands of appropriately trained individuals, has higher sensitivity and specificity for pneumonia compared to traditional chest radiography.
And you have mentioned that there is no universally accepted POCUS scanning or interpretation protocol. That does limit comparison across studies, but a commonly used protocol is the bed-lung ultrasound evaluation, or BLUE protocol. JAMA is publishing a video that outlines the steps in the BLUE protocol, so I won't ask you to describe it. But can you describe its sensitivity and specificity for diagnosing pneumonia?
Absolutely. BLUE protocol is a standardized scanning protocol that can be used to diagnose a variety of pulmonary conditions with point-of-care ultrasound, pneumonia being one of them. And in a meta-analysis that we reviewed, we found that the BLUE protocol had a very good sensitivity and specificity, sensitivity of about 0.88 and a specificity of 0.93 for the diagnosis of pneumonia. And that was compared to a reference standard that included a combined clinical suspicion, laboratory testing, and imaging. And that gets at the point you were making earlier, where there's no set gold standard test for pneumonia. And a lot of these studies have to look at composite reference standards when making that final determination.
Earlier in the podcast, you mentioned that POCUS training is not currently standardized across medical specialties or organizations. Can you discuss what the American Medical Association and the 2025 ATS Society guidelines state about who should be performing POCUS?
Yes, the American Medical Association does recognize the use of ultrasounds by clinicians and is considered part of their standard practice. And then the 2025 American Thoracic Society guidelines for the diagnosis and management of pneumonia do state that point-of-care ultrasound can be an appropriate diagnostic modality for pneumonia at medical centers with appropriate clinical expertise. And what I take this as is a new wave of a diagnostic tool and new evidence that is growing for the use of POCUS in the diagnosis of pneumonia. And of course, there are many other guidelines and randomized studies that have also begun to demonstrate the use of POCUS in a variety of settings for chest imaging.
And that leads me to my last question, which is, what do recent practice guidelines such as the ATS 2025 Clinical Practice Guideline on the Diagnosis and Management of Community-Acquired Pneumonia state about the use of POCUS as a diagnostic alternative to chest radiography for adults with suspected CAP?
Yeah, so the 2025 ATS guidelines state that POCUS is an acceptable diagnostic alternative to chest radiography in adults with suspected community-acquired pneumonia or CAP at medical centers that have appropriate expertise. And this gets at this point that it is a useful diagnostic tool, but expertise and familiarity with POCUS is really, really important. And although, as I mentioned earlier, there are societies and organizations that have their own credentialing pathways, individual institutions also may want to consider their own privileging pathways for point-of-care ultrasound, and many institutions are following that. And that will, over time, I'm hopeful, result in more standardization around POCUS.
Before closing, is there anything that we didn't discuss in this podcast that you'd like to mention?
One analogy I like to think of with POCUS as it relates to there's no standardization around it, and there's a variety of different interpretation of what defines expertise. It relates in many ways to the physical exam. I like to think of POCUS as a tool you can use at the bedside to improve your diagnosis and management of a patient, which is no different than what we're typically doing at the bedside with the other physical exam maneuvers.
Thank you so much for sharing your thoughts about this interesting and important topic.
Thank you.
I'm Dr. Kristin Walter. I've been speaking with Dr. Andre Kumar about point-of-care ultrasound for the diagnosis of pneumonia. You can find a link to the JAMA review article and an associated video in the episode description. This episode was produced by Dania Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.